Hello and welcome to Making Medicine Better. I'm David Morris, and joining me on the show today we have Wilby, Kirti, Yvonne and Jawad. And today we're going to be talking about the current state of medical education and whether it's preparing our future physicians and our future healthcare workers overall for the life that they're about to walk into. Over the past few episodes, we've talked a lot about the changing landscape in healthcare. We've talked about physician well-being and the rise of AI and technology in healthcare. One of the foundation blocks of healthcare overall is our workforce. And our workforce globally is lacking at the moment. We don't have enough people coming in or staying in healthcare. And really, if we think about our future clinicians, they are currently in or going into medical school over the next few years. And what we wanted to talk about today was really whether we're attracting and bringing in the right people to that system, whether that education is preparing them professionally to work in medicine into the future with all of the different changes that are coming, and whether that overall experience is preparing them as people to survive as healthcare workers in the future. What do you think? What type of people do you think medical schools are attracting today? Are we attracting enough people, or what should we be doing or looking at going forward?
I think variety is important and freedom of choice. And I think it's not necessarily about individuals or trying to understand, because we often do talk about that, about the qualities of a doctor or the persona of the perfect doctor, and make, judgments, either in our own practice or in our own experience with colleagues or in our own experience as patients. We make a comment, and often that's really subjective and kind of past remarkable to some extent, and we're responding to something maybe slightly emotionally. And I have the real privilege of working as a teacher. So I'm a professor in Trinity College Dublin. I support the education of medical school, and it's really inspiring. I'm inspired by the people I meet. It's one of the most culturally diverse experiences that I get to experience. And I'm enriched by the stories and narratives I hear. And I feel not only that privilege, but responsibility to try and do that better. And then that's something that I'm learning to do and improve in terms of becoming an educator and a teacher. But also it's about being a mentor and supporting people on their journeys. And I'm not sure that we have to expect of somebody who's coming into medical school and starting that journey, or starting a health professional training program of any description, of whether that journey has to necessarily end up into profession. I think maybe that's slightly outdated. But therein is some of the challenges in terms of there's maybe a lack of transparency in terms of what we're offering young people and what the expectations are for those young people. And can we match the diversity of personality, the diversity of skill set with job potential and career potential? But also comes back to me some of the previous conversations we've had about healthcare systems and what's the purpose of a healthcare system, and this word of like a sickness system, and then this idea of like the economy that matches that, which is kind of supply and demand, and we're the service provider to a customer. And I think we're not being transparent enough around that training in Ireland and the UK, which is where I've had that experience, is wrapped into service provision and demand and supply. And there's maybe a lack of transparency of the institutions that are involved in dictating that and planning that. And that's not clear to the young people that are coming into those training posts now. And then there's the fact of that we attract young people globally and from all over the world. And are we being equitable in offering those young people the same opportunities? And if somebody has made a choice to take an alternative career path, whatever that looks like, are we equitable and just in terms of supporting them on that decision, because they can still offer a lot of value, but that value might be unseen to us or outside the bounds of a traditional path. And so those are the things that I think about when I'm meeting all these wonderful young people that are trying to that I'm trying to describe ECGs to, and the left ventricular pressure volume loop and various slightly boring things that I'm not quite sure translates into their future careers.
But you make an interesting point there, Wilby, around the expectation of young people coming into this profession and into the healthcare world in general. In your experience, as you're seeing them come in today, are they coming in with a solid view of what they're walking into on the other side of their degrees, or have they either been receiving a different view of the world through public perception, through media, through the universities themselves, or are they coming in with a true view of what this career is going to look like?
I think that's so complex and challenging to answer, and like I can only answer it from maybe like my worldview, which, you know, what do I feel, you know, and this is probably more my opinion, is that we should be doing more to be transparent about what the vocation and the profession looks like, and that the ideals of that don't necessarily always marry with kind of the picture book perception of kind of what medicine is. But that's just my view, that I think we probably should do more to mentor, more to support, more to be transparent. So I use lots of narrative in my teaching, use lots of anecdote, just to try and contextualize why they're there and why I'm there. So, but I don't know, you know, that what impacts that. I don't know.
I thought I'd just come in here in terms of managing expectations. My father's a GP, and he worked 7 days a week for most of his life. I think he went down to 6 days a week when he was 65. So I grew up with that understanding of what was involved in this profession. I somehow thought it would not be relevant to me. So while I had first-hand experience, I thought it was going to be different. So I'm not quite sure that even when you're aware of what it is, you know, I think you still think you're going to do it differently. So I'm not completely sure awareness changes much. Going back to what you were asking about the type of person who should get into medical school, I don't think there is a particular type. I think medical school by its nature does actually accommodate a very, very wide diversity in terms of type of person. And I think we all respond to medical school differently. And I think in part, some of it does lead to the specialities we choose, you know. So in terms of our different personalities and what we end up doing in terms of speciality, I could never have done emergency medicine because I needed something calmer, something more analytical, something slower, which is why I did neurology. So I do think it does accommodate for certain differences. And I do think to a large extent it does prepare you for what you're going to do in terms of the varied experiences, the way I was trained, and I think certain things have changed. The very staggered approach to clinical medicine and to responsibility. So there was a very slow build up to the type of responsibility you had, you know, from first to just possibly doing basic sort of tests like taking blood tests or inserting an IV line, to making decisions, to more complicated procedures. And in part, it builds also that resilience that you need. But again, I think you need systems where this doesn't work for people, it needs some sort of support structure for people where this doesn't work.
Yeah, I mean, I think in the US at least, we had a very test-based admissions criteria, and I think that's no longer as relevant, especially as we come into all these, even for a long time now, even things like UpToDate and decision guidelines make the rote memorization of knowledge less relevant. And so I think just using, you know, MCAT scores is like a huge factor. I think we have to go beyond that, you know. In addition to like IQ, for example, we have to also look at EQ and some of the soft skills. Can this person engage with a complex environment? Can they lead a team? Can they, you know, negotiate for their practice? Can they build a business even? And then also, and then the third factor, I think you have to look at what unique things that this person bring that will contribute to lessening some of the health inequities and the lack of diversity in our health care workforce and also in our delivery. And so to me, I think that's a little bit different than the current model. And we don't have a great way to quantify those other two factors. I know, like at UT Austin Dell Med School, I helped review some of the applications for the pre-med students. They do a good job, I think, of trying to quantify some of the social experiences and diversity of that person, but there's no, like, it's not as easy as, they're in the top 10 percentile of test scores, right? So I think we still have to think of as a community, how do we quantify that? How do we stratify it? How do we make it more consistent across institutions? So I think in some ways we have a ways to go, but I hope we're working on it. I mean, that's in addition to all the conversations around, does the length of training need to be as long? And I'm sure we'll get into that.
That's kind of what I was thinking as you were going through it, Jawad, that point around traditionally we're very focused because it is the easiest objective thing to understand is to put someone through a test. How highly did you score? The vast majority of it being rote learned, and are you able to regurgitate that in an exam? Whereas I think if we can start to quantify and move towards a space where we're bringing in people with a more rounded set of emotional skills even to start with. Now you can start to develop that in people as they go through the training, and we'll talk about that in a minute, but to try and bring in people with a broader range of social experience, a broader set of emotional skills, they will have to have obviously the cognitive ability to manage medicine, which is really complex, and that's fine as well. And then having that diversity and that range of social experience, that range of cultural experience within a healthcare system, in your healthcare professionals is really important as well. Yvonne, do you have any thoughts on this piece, or do you want to come in on this?
Yeah, I'd like to come in. I just want to take a step back. For example, in my country, Cameroon, and in so many parts of Africa, like getting into medicine is often seen by some of the families as something, prestigious or worthwhile or good for the family, because in some settings it is like a means to an employment. Though in other settings you get in there because you want to save lives, but there's also a lot of the cultural. It's a noble profession, as it seems. In my country of about 15 million people, there was just one medical school, and you had to write an entrance examination to take 100 people per year. So 100 persons per year for a country of 15 million. No wonder we have like very few doctors per physician. And let's say we get in 100. By the time we finish school, how many of them are still there? Not to get down the specialization line, but not to talk about it. Like the exam was like regionalized, so we have 10 regions, and so they try to democratize it so that they take the 10 best candidates from each region in the aim to have some kind of regional representation, but at the same time, that means when you leave, you get into medical school at 18, so straight out of high school, which is somehow different from the US, in which you kind of have to have a first degree before getting to med school. Yeah, you get into med school straight out of high school, so 17 years, 18 years of age after your A levels. And it's always, put forward like one of the, if you're good in science, you pass like all the GCSEs and all those kinds of things, you're kind of oriented in either medicine or engineering, not a lot of diversity. Like these are the other options open to you. So some people like it. Some people go into it with the passion, like I want to, save lives. Other people go into it because it's also a means to an end. It means to an education. It means to provide food and a sense of livelihood for your family. Okay, so the way most of these people are really young, right? There's no way of testing all these other, developmental things, and will be mentioned is a journey. So once we start this journey, we may have one set of objectives, or we are still very much teenagers, right? We're still developing, right? And sometimes we're not quite sure who we are or what we really want. And by the end of this 7 years of training, which that's what happens. So 7 years means the first 3 years are like preclinical, and the next 4 years are clinical. We change along this journey, right? And sometimes there is no room to accommodate these changes. Like I got in there at 18. By the time I finish, I'm 24. I've developed in mind in so many different ways. And sometimes the expectations of me still stay the same like when I was 17. Like my mind improves. It gets broader throughout the 7 years. But sometimes you're kind of like saying, oh, I started with this dream. You have to follow this dream. So I kind of like that notion of like, how do we support different people along the different journeys, we all are on very different journeys. We have different things that make us tick, and we change as we go along the journey, right? And sometimes it's not enough support to the fact that no human being is static. And as we go through life, we have different pressures, we have different mindsets, we have different things that either empower us or make us shrink. So this whole process, is not sometimes embraced. And there's not a lot of, if we don't have enough doctor strength, we don't have a lot of mentors to support these young people starting, and all this space to let everybody grow and develop and go into whatever direction works for you. Sometimes that does not always happen. And so we feel like we're stuck in something when it's actually a profession where there is so much room to be yourself.
Yeah, it's like amazing, Yvonne. Like I like Kurti, Yvonne, Jawad, you like paint this story of like hope, and like being able to embrace kind of creativity, like, and I think that's that juxtaposition between that hope and energy and the potential that we have, and then these systems that we come into. And like Kurti, you described it really nicely, like the kind of nurturing element and allowing people to have space on that path. And I feel that we're kind of losing that a little bit. I feel that, that embracing that diversity and allowing people to mature and develop on their paths. I'm kind of caught in two minds, because like, should we be nurturing and slowing things up a little bit, or should we be speeding things up? Because actually a lot of service provision is like 8 years of a waste. You're just stuck in like middle grade doctoring land, and like, is that really necessary? So how do you get that compromise right? Nurturing, but also allowing people to fast track if they really want to go fast.
Yeah, I mean, I think you can have both in some ways, by just creating paths. I mean, I think, you definitely need a lot of physicians to go into primary care, and you can have a fast-tracked way. I mean, a lot of countries outside the U.S. have that, right, where it's like 5 years after high school, and you can become like a primary care physician. And then if you want to do a subspecialty, you can take more time to do that. And then also more and more schools in the U.S., at least, I'm sure other places also have the option. If you want to do like a MD, PhD, go the research route, do an MD, MBA, go the entrepreneurship route, or do some people have like an MD, JD, and if you want to go less common along that route. But I think there should be a basic pathway that you can become a physician in 5 years, like after high school, or let's say you do like college plus 4 years, and then that includes your residency. Because in the U.S., the minimum amount of training is usually 4 years of college, 4 years of med school, 3 years of residency. It's 11 years after high school. It's a long time, and that whole time, except for residency, you get paid, but for at least 8 years, you're paying tuition and not making an income. For the most part, and so I mean. And then people come out of it like hundreds of thousands of dollars of debt, and now their hands are tied as far as their opportunities, because they have to pay that loan back, and so I agree. I mean, it's a combination of accommodating people's dreams, but you also have to do it in a realistic way that allows them to move forward with their life. Like if they want to have a family, if they want to buy a house, if they want to do these things, you can't let them picking a medical profession be such a huge obstacle to those goals.
The thing that I notice that it's kind of in line with Yvonne's point a little bit, actually, is that, and you see it every summer, you'll be familiar with the phenomenon here. When you watch our national news channel, when everybody gets their end of year school results and they're finishing high school here, you'll get the news companies will go around to the schools that had the straight A students, and they'll, oh, Mary got 600 points, and surely, Mary, you're going to go off and study medicine, aren't you? And that's the expectation. I don't think she'd ever thought about it in her life, but because she's got such a high grade in school, it's expected, and it's going to be a very proud day for her family that she gets to go off and be a doctor. And I think there's still a huge amount of we've put some like MCAT type, so aptitude type tests in the way as well. So it was purely based on points, but it's not quite so bad anymore. But there's still that element of, if you've got the points, if you've got the kind of the result to do it, then it's expected that you will go and study medicine. I think we're getting a lot of people like that still, going through and just doing it because it's expected culturally, that if you have the opportunity, you should, whether you want to or not.
I think there's truth in that on some level, but I think it's not just true of medicine in terms of using a grade to decide who gets to do what. But I also think that unless you actually change the syllabus for medical school, I don't know that a person who's not able to pass those exams at that level and that degree of focus and commitment will actually get through medical school. And so I think it ends up being a proxy for the ability to do that. And so unless you change syllabus, I think you can't change the selection criteria.
Yeah, no, I think that's really important. I think absolutely there has to be an element of cognitive ability to get through the level of information, the amount of stuff that's going to be thrown at you and the speed that is going to be thrown at you through medical school, for sure, definitely. And to that point then, to move forward to the actual education. So we've got these young people now, we've brought them into medical school through whatever view of the world that they have, and they've managed to get the grades. They're now in medical school. Are we giving them the right preparation to go into this world of medicine that they're about to face? So when they come out at the end of a medical degree, have we given them all of the tools they need professionally? So we'll talk about themselves as people in a minute, but professionally, to work as doctors, do you think people are coming out prepared?
I mean, I think the answer is no. I mean, I think to your earlier point, do the smartest kids still want to go into medicine? I think here in the U.S. that's not necessarily the case anymore, and I think and for a lot of reasons, right? One of those is they can make more money faster working less in other jobs. So that's one part of it, and also I think just the healthcare environment is no longer as idyllic as it was maybe in the past. Not to say it was ever perfect, but then I think once you get into medical school, like Gertie said, you do have to have a certain amount of ability to put in the hours and study and focus and do that, because they do require you to memorize and handle a lot of information. Should that be the case? I don't think so. I mean, I don't think you should have to memorize 1,000 pharmaceutical drugs anymore. I mean, is that really relevant? I think you should have to be able to critically assess information and have a knowledge base to which to compare it to, so that when you're using these clinical tools in your practice, you can have some kind of a context with which to assess, is this thing pointing me in the right direction or the wrong direction, and not just be totally reliant on whatever tool you're using. But do you have to memorize all of that? I don't think so. And so I think you can change the syllabus, and thereby you can change the criteria for people entering the school, and then you can also change the amount of time you have to spend on the pure clinical side, because there are other things that we don't talk about. Like, for example, we don't talk about nutrition very much. We don't talk about care delivery systems very much. We don't talk about the actual, environment of care, like HMO versus PPO. What's a payer? What's a PBM? In the US, it's so complex, and physicians come out really having no idea of any of that, apart from the pathophysiology and treatment algorithm. And so I think there's a lot of opportunities to cut down some of the information we're making people memorize, and then add more relevant pieces of information to make them more well-rounded, and also shorten the time limit. I mean, I know Gertie and Yvonne mentioned practicing clinically in late teens, early 20s. When in the US, you don't practice, as an MD, the earliest you practice is 26, and that's in a training environment, and the earliest you practice as an independent physician is really at 29.
That's an interesting point. I think my personal experience, I was really lucky actually. So I went back into medicine as a graduate. So I did an accelerated medical degree in 4 years. I was in one of the first universities to try problem-based learning. So we got very, very little didactic lectures. We had 2 hours of lectures every week. And we had, apart from that, here's your problem, here's a set of symptoms. Then sit in groups and go away and figure out what this disease is and learn everything about it, and come back and figure it out as a group. And that's how we studied for the first 2 years, and our second 2 years were clinical practice. But that's very different to the way a lot of universities are still doing it, and just making you memorize everything. But the point that was made to us when we were starting is that the world is shifting, it's changing. And to your point, Jawad, when you've got systems behind you, even today, you've got systems like UpToDate, you've got publications, you've got search engines, you've got ways of finding the information. So the the shift should be, in my opinion, should be to enable you to know what's good information and bad information, instead of trying to memorize every drug in the book and the pathophysiology of every potential illness. You need to know, you need to have a certain amount of knowledge, you need to have a certain amount of base knowledge to have a gut instinct to be able to figure stuff out. But then the biggest thing is that you're able to go and find the information if you don't have it. Is our education training people to do that now, or does it need to move further into that space, guys? What do you think?
I wonder if I could just come in there and maybe just provide a contrast to it, because I was wondering how you actually do it differently. Because in part, actually, doing all of that, and our training is different, like I say, because I would have done 3 years basically without clinical work. By the 4th year, I'm in a hospital, very, very supervised situation and very minimal responsibility. So my learning would have been in a hospital, seeing people in a hospital and being trained. But part of the process of actually learning for that first 3 years was a lot of memorizing. But in part, it trained me to think, to analyze, to remember. So I built these algorithms in my head, right? So that I could actually understand the steps that I needed to do beyond that. And I'm not sure that I'm not sure what you replaced it with is my point. I don't think it's good enough to say information sources are there, because in part, that process of learning teaches you or trains your brain in a specific way. It's not just that I learned to remember. I learned how to learn. I learned how to analyze. I learned how to think critically in that process. I learned what I needed to forget and what I needed to remember, both in terms of a clinical setting and to pass an examination, So I think it teaches you these processes. I do agree the volumes can be overwhelming and there must be a way to actually adjust this. I'm just not sure that the replacement with saying, here's an information source. And I do see a lot of younger doctors going into their phones while they're actually being trained, right? So while the tutorial's actually happening, their focus and attention is not actually there anymore, right? Because they know they can just look at a phone. But I'm not sure that's necessarily the right way. And again, looking at brain health and how our brains work, we train our brains in a specific way. Those specific parts develop. It helps us to do the tasks we need to do, not just remember, right? If I learn to play the piano, the parts of my brain that are developed further are the parts that play the piano. So that's the struggle I have with just the replacement of learning. What you replaced it with.
I guess to that point, I suppose I probably describe it wrong from what I've described there. I think the piece around the problem-based learning, so definitely was a bigger focus around reducing the volume. But there was still a hell of a lot of learning. It just wasn't fed to you in a didactic form. So you didn't sit in a lecture and blindly suck it in. Actually, we probably learned harder and faster to take everything in the 2 years that we did it, but it was more self-directed. You figured out what you needed to learn and you memorized that. And at the end of every year, we still had to sit there and do a blind exam. So we still had to memorize everything. So it's not getting rid of the memorization. It's just learning it in a different way, taking in the most important stuff, learning what's the most important stuff to remember, and reducing the absolute volume of memorizing, but still you have a lot of it. Yeah,
I think I resonate with kind of both. I think I'm on that continuum of that you're describing, both David and Kurti, and I just can think of it personally that I came to that a little bit earlier. I'm a bit slow to the game, and I didn't develop my understanding of my personal learning styles until later, and I probably embrace more or learn or are more successful with the kind of the strategies that David describes. And it was this combination of real world experience, but also I was getting myself into postgraduate training programs and doing masters, and those masters programs opened up this problem-based and group-based learning. And then I had the good fortune of then I was working part-time as a doctor at the same time, and the combination of those two worlds where I had real-time responsibility but also space and time to do quite deep learning started to put me in a path where I learned better, as opposed to the rote learning approach that I experienced in med school, where I was kind of more at a, you're in a often majority in a class of like 200 to 300 people, and very kind of rote learning type of style, and you're kind of regurgitating in true, false, and MCQ styles. That volume-based approach of just trying to get that knowledge into us didn't quite resonate with me. But it's how do we replicate that, or how do we make that modular or grow that for people? and make it into a system.
So I think just to kind of bring a point on that, I think what we're saying is there's a happy medium in the middle, where I think there's the need to move away from trying to cram volumes of medical texts into people's brains. We need to bring the type of training that doctors get into a space where they are able to think more autonomously, where they're able to figure out what they need to remember a lot of it, and know a lot of information to be able to look at a patient, analyze a set of symptoms or lab results and everything, and figure that out without going to their phone every time. But also being able, in this world where there's so much data available and so much new information constantly, that they are able and trained to go and find the right information and sift the good from the bad. And I think that's a really important piece.
For sure. And I think as we get into AI tools, even to understand how to critically analyze these tools to see which ones you can trust and how much you can trust them, and how to look for errors in their outputs and things like that, I think is important. And right now, no one's even talking about it.
Yeah, like problem solving and critical evaluation. But as you guys were kind of talking before, about, I don't think it's just about being able to access that information. I think it's about being able to communicate that information and make it accessible, especially with devices and things like that. But I guess it gets wrapped up into informed consent and those types of things as well.
And there's two things I want to bring in here then. There's the way we teach people and how we get the information and bring them along the journey. But there's also a shift in healthcare. If we think about where healthcare is going in 5, 10, 15, 20 years. So if we look forward, there's going to be loads of technology. It's going to be augmenting us, hopefully, and we're going to have to work with that as physicians and healthcare workers overall. And then the other shift that's coming is that move that absolutely has to be made from where we talked about in a couple of episodes ago, around 80% of our current care is reactive and 20% is proactive. And we need, I think it was Igor that was saying we need to flip that. Are the clinicians that we're training today, are they being trained in that culture where they're going to be more proactive? Are they ready to be more proactive and to talk about everything that they need to talk about in there? And to Wilby's point, are they going to be able to communicate that information well to a patient? Or do we need to shift something in our training?
I mean, I think at least here, the problem is that the system doesn't incentivize any kind of proactive care, right? Only incentivizes, fee-for-service procedural care for the most part. And I think you have to really change the model because I think, at least like in a capitalist society, what drives behavior is money, just to put it bluntly. And I think if you want to have a proactive healthcare system, you have to make it financially viable to do so. And I think that's the problem, is that the current situation doesn't do that. And a lot of people who are doing well right now are going to have to either not do well or change the whole model to allow that. And so I think that's a big obstacle.
So there's a challenge to bringing that into medical education until the system is ready to accept that as a big piece, I think is what we're...
Yeah, because like if I am super well trained on like population health and health prevention and health maintenance, and then I go out and like the job that I get with those skills is not paying very much, like it's hard to motivate people to do that.
I think you raise a really interesting point, Jawed, and it's probably the one that I'm challenged with, or what I was kind of getting at the start of a conversation, is like this complexity of kind of what we're doing in this kind of personal journey of education and medical school, and then these systems and the service industries that they come into, and then I think of Yvonne and the description that Yvonne's given about the movement of people. And when we think about the global south and the access to healthcare and access to doctors, and then here in Ireland where we have challenges in terms of supporting everybody to have equitable access to training and to access and enter specialist higher training, and the same happens in the UK. It's not an even playing field, and yet we're drawing people from global south into Europe and North America to work, but then we're not giving them the same opportunities, whether that's because of law or not. I struggle to see how we don't take a step back and say we need to look at this as if it's economically, we need to look at it as a global economy. If it's from a more societal humanity base, we need to look at it, a lot harder and stronger and faster, and kind of, at the minute is just kind of a little bit of a one-way stream, it feels for me, and it's just from observation. It's a capitalist user system where we're using human capital that's generated elsewhere, and it's kind of something that I'm challenged by in terms of when I'm then at a mentor role, or helping to support junior doctors in Ireland and the UK, when I know that they may not have the same opportunities, and I feel a little bit powerless to be able to impact that.
Just taking a step back and talking about like how we are educated, just like really to agree what David was saying, like we kind of need a bit of both in our setting. Like most of the books we use, which is normal, are written by Caucasian authors, right? So we use like similar books which are used in the UK and the US for our training, but the environments in which we work are vastly different. So a lot of our training, we'll talk about certain like equipment, certain tests that you may go through medical school and see just once or twice. And our training sometimes not adapted to the setting and to the environment in which you find yourself and you're working in. So if you're taking a textbook and it's describing like all the blood tests, the ECGs, the things which are like MRIs, just the things which in the West are considered routine healthcare, but while in many parts of sub-Saharan Africa, you would see those tests only like in the referral hospitals, in the best hospitals. In some of these patients, most of these patients pay out of pocket for healthcare. So your textbook would tell you like, oh, to make a diagnosis of XYZ, you have to ask for XY, this test, that MRI, that scan. And the practice is that that would be possible maybe for 2 in 10 patients. For the majority of patients, you have to make use of very good clinical skills, like you have to listen to the patient, you have to take a detailed physical examination, you would have to make sometimes the best guess. And sometimes even in treating a patient, you will go from this is my best hypothesis and I will go backwards. So a lot of times the books you use for your training do not match the reality you face on the ground. It's two ways. One way is that you're trained to use your physical senses and your clinical skills, like your training in your physical examination is so important because sometimes that's all you would have to deal with. But the reality is that that's not what the textbooks, that's not what if you go on Google would say. Our realities are sometimes different. Take dermatology, right? And you're looking at, skin lesions. Most of what you see as skin lesions on Caucasian skin. Now, when it comes to like dermatology for brown skin, for dark skin, which will be the 99.9% of the patients you will see, right? You have nothing to compare that with. So we need to have medical education, which is context specific. We need to have, which is down to us as well. We need to have books and texts written by us, for our settings, adapted to our settings, and taking into consideration advances in health, but these advances are not advancing at the same rate. So for many parts of the population, we're still dealing with where medicine was practiced maybe in the 90s. Take a simple thing like what breast cancer. It's assumed that you know what's the ER status, the hormone receptor status of a patient. Assume you even know the genetics, BRCA1, BRCA2. That will be not the reality. So a lot of times that is not your reality. So we need to like readapt our training to make the best of what we have, in the sense like if we're good with our clinical skills, you maximize that. We need to leverage on our skills. A lot of times we feel that that what comes from outside is better, but you have strengths because of the fact that you have to deal so much with your hands and your listening and auscultation and all those really basic skills. So you learn to become like really good at using your hands, and you're really listening and trying to all those kinds of skills, but you're not really 100% when it comes to like interpreting an ECG, looking at a CT scan, because that's not your reality. So it's a way we have to think about how to strengthen health systems, such that the clinicians are trained in a way which is adaptable to what they will experience. We need to have text and research which is context specific, because a lot of the research we have, whether it comes to like epidemiology or whatever, most often is written, with a Western point of view. But you need to have things which are adapted. Now, when it talks to like clinical trials, side effects of medications, most of this are still done in Western settings. So a lot of times you are copying something which is not adapted to you, and you're trying to apply that to a population which is not adapted to it. So I think we really need a rethink of how we practice medicine. We need to embrace some of our cultural realities. We need to strengthen what are our strengths and try to see how we, leapfrog, in some other aspects. So we have a long way to go in medicine. Sometimes we come out here, we get you get trained, and you want to go back, and a lot of the equipment you use here are not present there. So sometimes you go back, you would try to really reintegrate and really go back and do your best, but sometimes you're not trained to work in those settings, and lots of people come back to the West. So we have to make systems which are, you know, which reflect reality. We need to support people as they try to use those skills in the environment they have, which is sometimes challenging. But I think it should be a continuous work in progress.
Yvonne, like I'm really interested, and maybe it's a slight bias from recent reading and looking at kind of Lancet Oncology commissions on improving access to care and thinking about that from a perspective of the Global South. And that gap you describe in terms of access, the solutions to that are being described with a very Western perspective. Build more, like release 216 billion to build MRI scans and CT scans and improve access. But I don't see like this thing that comes back to the kind of the education and the creativity and all those young, brilliant minds that are being selected into those schools. And then it's like, how do we support them to not adopt a Western model, but to come up with new innovation, like new technologies? So one of the things I've been Googling myself and trying to search for is new innovations in imaging. And I can't find anything. It's like we're stuck in innovation in Jawad's world of like innovation of post acquiring analytics. How do we make our AI better for our MRI or echo or our CT? I can't see the science that's out there. Go, how do I improve handheld diagnosis for breast cancer in resource depleted areas or culturally rich places? I don't want to use negative terminology, but it's just like where's that innovation? Why do we have to close a gap with a Western model when it doesn't necessarily work or it's not going to be sustainable?
No, I agree with you completely, Yvonne and Mulby, actually. So I think particularly as you get older in terms of medicine, you realize how much of our training is so based on sort of a Western book. But I think clinical skills are unmatched, and I think that is our advantage. Our clinical skills are our advantage. That is how we practice medicine. And I think they can't be replaced actually by MRIs and the rest of it. But I do see huge problems in terms of the way we actually decide what's next, like you're saying, in terms of CT scans, MRIs, and we don't have it. And we need to actually adapt our system to understand that. So who gets referred for the MRI, who's it going to benefit the most, and how to make those selection criteria. So we have to adapt in terms of context, like you're saying. And I think even beyond that, because all these books are written somewhere else, signs and symptoms are different, I kept trying to work out, why is this not working? And so we have to be very adaptable, and we are very adaptable. But I kept trying to work out, why is this not working? And now I've realized it's not working because it's not written for the people I'm seeing. So the signs and symptoms don't actually match. And a lot of neurology, I have to listen and I have to examine, right? So yeah, I do think we have to adapt for context.
Exactly, Kitty. What you say even about symptoms, the way patients would describe their symptom of pain or something is completely different from what you have in the book. Sometimes there's no terminology in their language to say, this is how I feel about something. So it's like really going and trying to really listen, not just with your head. Really listen to what the person is trying to say and how the person is trying to express themselves and express what they are feeling. But you're right, our clinical skills are gold standard, because you're so trained in clinical, because sometimes that's all you have. And it's sometimes the difference between life and death, being able to really pay attention to what you're listening to on your stethoscope. But you also put a lot of responsibility in your arm, because you say, if I miss this patient can go. So, which is sometimes a lot for a young person. By the time you're finished 24 and you're like, I have to make a diagnosis based on very minimal things I have on my hand, but I have to do the best. And when errors happen, you kind of sometimes take on that responsibility, like, if this was better, I could have made a different diagnosis.
Agreed.
So it's they need to be supported.
It's a very, very important point, I think, though. And I think that it counts overall for everywhere that we train. So definitely in the world that you're describing, Yvonne and Kirti as well, there's the context in which you practice is going to be totally different from a textbook. The textbooks are relatively standard. They're probably written a little bit of time ago, to be fair. They're also not written for every culture that you practice in. But I think there's a broader piece as well, that even to Jawad's point at the start, that we're not training the doctors, even in the US, for the context of the world and the system that they're going to walk into. They're still being trained from a textbook to learn about signs and symptoms, and then they're landing totally unknown to them into a system that's incredibly complex. So it's a different issue, but it's again a context of where you're going to practice. You're going to walk into a world where you might not think the patient needs an MRI, but because it's a fee-for-service world, we're going to do one. So that's part of, where there's a whole load of important context that I think people as they're training need to do. Jawad, there was a point made as we went through that there, though, around innovation and technology. Do you think that there's an important piece around bringing technology closer into the curriculum as we go through medical training, and making sure that people are more aware of it, that they're thinking about it, that they're thinking about how to innovate, that we're training doctors as they're training doctors, we're training them how to innovate and how to think about innovating and how to start inventing the new things, so that we don't have tech people driving the future of healthcare. We have doctors who are being kind of taught to innovate all the way through.
Yeah, I mean, first of all, I just want to kind of reflect on the points that Yvonne and Kirti brought up. I mean, I think, that's a great point, that the resources that the students there have to learn from are not reflective of their environment. And how do you make those resources for your own students? I guess the local infrastructure just has to support that. I mean, I would think, and I guess how do you push towards that? I mean, that's an interesting point. Even as thinking about physicians as advocates, and things like that. And then to your question, David, I mean, I think several different things. I mean, I think a lot of physicians are getting into innovation and tech, and I think that's partially a reaction to the healthcare environment. They're looking for things to do outside of direct patient care, and I think it's not necessarily a physician's job to build the next generation of technology, but I do think physicians and clinicians in general should be involved in the development of it, just so what comes out of it is reflective of the needs of the patient, and also reflective of the work that the clinician does, and doesn't add to making the clinician environment more onerous. And so I think we should be trained to integrate with industry. And I think similarly, industry should be incentivized to put the clinician needs into their, end output and process. And I think it's happening more and more, because as the clinician workforce crisis gets worse, the improvement of the clinician situation, like, the changing it from the triple aim to the quadruple aim, with the fourth aim being the clinician, I think that's more and more relevant, because that's in and of itself its own ROI. And so I think industry and health tech is more and more inclusive of the clinician, which is a good thing. I think the specific area for clinicians to be educated as far as innovation is in terms of artificial intelligence, because that's a technology that is sometimes deceptively complicated. Just because it spits out something at you, it doesn't mean you can just take that at face value. So I think that's a huge area that we're not training physicians to appropriately engage with. I think other things like surgical tools, robotics, and stuff like that are pretty straightforward. But I think AI is a tool that is much more nuanced, and that we really need to kind of make sure that students and even practicing clinicians understand how to engage with it.
Yeah, and I think that's really important. It goes back to the point that we made, and I think we mentioned this as well when we were talking about the AI chatbots a couple of weeks ago, is around if our future physicians are so used to just sitting and kind of using AI as their primary tool, they will never learn the difference. When the AI spits out a bad result, they're not going to be able to see the difference if they haven't gone through the standard errors and looked at everything and understand the technology, learned the same way as everybody else did before them. If they're just depending on the AI and they take everything it spits out, there's going to be issues there. So there's a piece around having both sides there so that they understand.
I think we probably could be doing more. Like I'm thinking of like when I was in med school, I did 2 weeks of ophthalmology, 2 weeks of ENT, and 2 weeks of something else. Can't remember what it was. It was specials, ophthalmology, ENT, dermatology. It might have been. I was like, and that was it. And then I had to do an exam and that stuff. And it was just like, why couldn't we be take that same approach? Okay, they need to do a bit of this. They have to be immersed and learn some of this language and study a bit of this. And like, why couldn't we be putting them into medical technology or analysis of medical imaging or cultural sensitivity in your practice or understanding culture and diversity? Because I certainly wasn't trained appropriately to then move into a culturally diverse community working in the UK. And especially when I moved to London and this metropolis and cultural diversity, and like Yvonne, I'd never treated sickle cell before, and then I landed in Isleworth and central Middlesex, and lots of young people were presenting with sickle cell, and my medical school hadn't taught me about that, and my junior years hadn't taught me about that, and I was like, oh, wait a minute, this is and I had no sensitivity in terms of what that meant for the individuals and the presentations in pain and crisis. So like, I think it's not just, I think that traditional model of medicine and the teaching of medicine and that textbook practice, it's maybe just not culturally sensitive, full stop, regardless of where it is, because it's not reflective of the global world that we then go to work in as doctors.
I will also say in terms of my medical school training though, because there were definite issues in it, in terms of when I started, it was still apartheid South Africa. But the people I had to treat were very diverse. And so I had to be, and so you learned. There was no way I could not be adaptable and accommodating and change. And I don't know that medical school can teach everything, so it's about how you learn from everyone around you as well. And so how do you create that system, like in terms of who you learn from? And there are obviously huge gaps. I mean, one of the most valuable learning experiences was working with my dad for a short time, just in terms of that personal skill that he had. I didn't learn that in any system. That was from the privilege of working with my father, actually. And so there was a definite lack in the system in terms of an education level, but it's where do we learn from around the system as well.
Oh, I'm smiling because like just this personal anecdote in terms of like how I'm good with helping with kids with temperatures and getting fluids and paracetamol into them. That wasn't learned in med school or in AD. That was from my sister, who's a pediatric nurse. And me supporting her, bringing up her kids. Here, this is how you do it.
Exactly.
Get that paracetamol into them. So what is that? That's that's very holistic, isn't it? Or it's very. I learned it from my family, my kin, how to do that.
It's generations and generations of community learning. It's how people always did it, isn't it? It's
exactly.
the reality.
Yeah. Similar to my dad is a doctor, so I grew up kind of watching him examine patients, and I kind of got it from very early on that medicine was both a science and an art. There was all the scientific things you needed to learn, but there was also the art of healing, the art of listening to somebody, the art of making somebody feel better just by feeling that you see me, you see where I'm coming from, you see me. And it was completely different. It was different from what you it was not about speed at which you see one patient to the next. It was not like a 10-minute consultation, no, or about money out of it. It was about, listening to somebody and trying to heal them, which was, I call that the art of it. But you had to learn the science to be able to practice the art. And which I found it really, a different perspective of it, and trying to see the whole person in medicine as opposed to systems, as opposed to like, a heart problem or a neurologic problem. Like, who is this person? Where are you coming from? What are your social determinants? All that, seeing the whole person and not just an illness. And sometimes these are what I felt like maybe needed a little bit more in training. Like sometimes in our training we're focused about diseases of different systems, but what about listening to a human, to a person, and trying to put all of those things in perspective, and above all the ability to critically think and to keep learning, that humility to keep learning. I think it's so important because the world would change, our patients would change, knowledge would change. But if we need to inculcate the fact that we need to be continuous learning, like learn all the time, and also because within the joy of not knowing, and be comfortable with not knowing things, and being, saying I can learn new things, I can learn from everybody, the nurses, the community workers, because without that humility and that willingness to keep learning, sometimes we may, yeah.
Evan, I'd love to know how we put that art back in though, or how we build it in this kind of curriculum-based learning. And I'm smiling because the early exposure I got to education is I was doing a course in Cambridge. I was in Cambridge for a year, and I took on the role of a clinic tutor, and I had third-year medical students, and I focused on this stuff. I focused on communication. So on my rounding in the evenings, I found patients, and I went and I worked more on communication skills and how they deal with the context if they were presented with it. And then they complained because I wasn't giving them hard enough time, and I wasn't drilling in the diagnosis, and
it was all too soft.
It wasn't fitting their system, and I've got exams to do. Are you going to help me pass these exams? It's like, So, a one-man band trying to teach the art wasn't the way forward.
I totally understand that will be. But I guess if I put my...
How do we do it?
I don't know. That's a good question. That's like, how do we put that back into the system? How can we slow the system? How can we focus on the things which are most important? At the end of the day, if any of us are patients and we go to see a clinician, what would we want that clinician to do or to treat us, right? And if we kind of put on that hat, like, how do I want to be treated if I'm a patient tomorrow? Maybe it could help us design how we want, the medical system and the health system to look like, if we swap roles a little bit.
It's a really, really good point. The last thing I want to just ask very quickly about, and it's a piece that's important, and we talked in our first episode to Dyke Drummond around physician suicide and physician burnout and all of those, the nasty side of what happens to a lot of these young, energized, enthusiastic people who go into medicine and perhaps then struggle as they're going through it. But does our medical education, there is a responsibility on the system, not to make an environment that puts them under that much pressure that they can't cope. So there is a systemic responsibility there. But also, is the education system and is medical training doing enough for doctors and healthcare workers overall to help them have enough self-awareness, enough stress management, trauma awareness? Because we do experience things as doctors, but are we being, in today's world, are we being taught to be self-aware enough and to manage that?
So again, I do wonder how much is the responsibility of a medical school, and not just a medical school, even a schooling system as a whole, and how much is the responsibility of a society, and what this tells us about our society as a reflection, in terms of us not coping and not developing those skills. What are we losing in our society that perhaps we had before? And so I think it's a bigger problem in terms of what I see. I agree that the medical school system should also incorporate some of it. But even when I look at a schooling system, from a more junior level, I don't think a schooling system can do everything. We do need to look at our society and how it's changing and how it's not giving us these skills. Because again, in my practice, I was seeing much younger people just not coping anymore with with things that I would interpret as copable, and that's debatable, but it meant that they didn't have the skills and they weren't learning it from the generations as we would normally have learned, and that's what I was seeing. And it's how do we respond as a bigger whole?
Kurt, I'd agree with that. And like, it's only recently really, I've had the privilege of working with teams of clinical psychologists that have in community practice. And it's only really in the last year or 18 months that I've become more aware of trauma-based care and trauma-based approaches and how prevalent it is across society and across and how prevalent it is in terms of more lower socioeconomic context as well. So like, it definitely is something that was very absent from my learning and then as a default, like my personal development in terms of how to deal with trauma.
There's definitely a societal aspect to it, Kirsty. I agree. In my opinion, though, I think there's a piece where if we want to start shifting, so the culture of medicine as a whole is currently, it's clear, it's obvious. We've got more burnt out doctors than we've ever had before. We've got a much more stressed workforce. We're losing clinicians at a rate of knots, and the system can't afford to keep doing that. So there is something, a combination of that societal effect of people struggling to manage with things, but also the system putting more pressure on them and doctors then just suffering through that. And I think if we're going to start to shift that culture, we should try and start to shift that culture in medical school and during their early education, where they say, look, you have to look after yourself to be able to look after everybody else. Here's how you do that. If they don't have it as a society, we should put some element of it in trauma awareness and stress management and just self-care as a basic into medical education, I think.
No, I do agree with that. And in part, I had to be quite determined in terms of when I was in private practice, because the expectation was that I was going to work 7 days a week and be on call 7 days a week forever. I mean, how is this physically, practically possible? And so mine was I wasn't doing calls, but and I would take 1 weekend off a month. And it was looked at as sort of almost being, not as determined and focused as everybody else. But so I completely agree.
That 1 weekend off a month. Slacker.
So I do agree with you. I completely agree with you as well. Both has to happen.
It's interesting that you brought it into that conversation around trauma, because actually I was just chatting to Aoife today, I'm his wife, and I was like, she was asking, what are you guys talking about tonight? And I was like, medical training. And the thing that came into my mind this morning on the commute to work was actually some trauma experience as a junior doctor. Unfortunately, when I had a young lady in her 40s pass away from a lung cancer, and I was a junior doctor on the nights, and it was the first time I was on nights, and this lady had asked to stop her morphine and her diazepam because she was feeling sedated. And then I land in when she's in crisis and pain, and I didn't know what to do, but neither did the team around me, and the team didn't really care. And there was this registrar down in the acute medical admissions unit, and he was like, "You're a doctor, sort it out." And that puts the phone down. And then I'm like, I still, it was the first time I was giving morphine. It was the first time I was giving diazepam. And unfortunately, that lady passed away that night. And then I was just left feeling that, there's these hours of that lady and her final hours of, this physical life. And that I was there with this duty as a doctor, not really knowing what to do or how to support her. And then I didn't know how to react to it after. And the medical team didn't care the next day. They were like, yeah, whatever. And I was like, I feel a bit, I don't know what to do. And I went and found the Marie Curie nurse and the palliative care nurse. And I was just like, what do I do? I don't want to do that again. I want to make sure that I don't do that as a doctor. And I want to make sure that we care for that better. And that's something that stuck with me. That's kind of what's, when Aoife asked, I was like, boom, that's popped in. These experiences of which that was part medical knowledge, but also part in terms of communication and the experience of dying in a medical institution, which comes back to that definitely needs more. But there's obviously lots of science, but it needs lots more community and culture and sensitivity that I wasn't taught in the medical school.
Sylvia, that's so right, and I can totally relate to that as well. In the sense, like you go through a lot of traumatic experiences, but there are no mechanisms. So, for example, in a training, for you to like talk about it, release it, just kind of heal yourself of some of these things which you keep carrying patient or after patient until sometimes you kind of get burnt out because even as a student by the time you finish because there's no way of healing yourself even as you keep going through all these traumatic experiences, and you don't even have sometimes you don't even talk about it with your colleagues because you kind of blame yourself. You don't want to be seen as not a very good doctor or not very decisive, and we're all human. There's no way in which somewhere behind our heads we don't ask yourself that if I knew better maybe this patient would have survived, if I don't. But you kind of carry all of this without particularly in a setting, without settings where you can just sit down, think about these things, talk about these things, and let everybody know that you're not alone. You're not feeling this by yourself. But sometimes this feeling of either failures or isolation or just the fact that it's too much takes that enthusiasm out of you. Like you started feeling you could save the world, and by the time you're 7 years down the line, you just don't have it anymore in you. So I really think we really need to take care of our medical students, encourage them to take care of themselves, not just mentally, but in our society sometimes practically, like making sure it's not a given in some environments that medical doctors are immunized for things which they can so things which they can pick up in the hospital. In some settings, my setting, there is no medical insurance for a medical student. So you're, working so hard every day, putting yourself at risk. And sometimes if you fall sick, it's left to your family to pick up the pieces. And it's the same thing that happens up, even right into practice. So we need to take care of the people who have to give themselves for others or take care of others. We can't give out of an empty vessel. And if we start prioritizing and treating these people as the way they deserve to be treated, whether it's our medics, our nurses, our psychosocial workers, everybody who carries the brunt of the world on them, we need to treat them as royalty, because without feeling them, they can't, feel others. So I really think it should be a priority, making sure that the medical practitioner, doctor feels valued, feels taken care of, feels like, oh, my cup is being refilled so that, I can keep going longer.
And it's giving them the agency and the kind of the empowerment to actually feel that they can
Yeah.
be taken care of and look after themselves. Because I think that culture starts sometimes in medical school. It may be shifting, I don't know, but that it's a macho thing. You can't express weakness. You can't be sad because your patient died. So if Wilby was upset after that experience, his team would have thought he was a weakling. And why? Come on, crack on. You're a doctor. Deal with it was the answer. You've seen it. And we've all been there. And there's that piece around being the macho doctor, but there's also the piece around not wanting, as you described, Yvonne, around not letting your team down, not putting extra pressure on other people. And it's the simple things around standing in an emergency department and not wanting to take a toilet break because it's so busy, not wanting to take your lunch because it's so busy, and you've done a 12-hour shift, you've been on your feet the whole time, you haven't eaten, you haven't drank, you haven't been to the bathroom. I mean, how effective of a doctor are you going to be at that point? You're not. And you can't sustain that, and you can't sustain 7 days a week, Kirti, like you're expected to. You can't. Nobody can do that. So I think when we're in medical school, it's to start to shift that, and for doctors and trainee healthcare workers everywhere to understand that if you're not looking after yourself, if you're not pushing back on suggestions like that, if you're not making sure that your cup is full before you deal with everybody else, this is going to be a bigger issue. You're just not going to last in that career. It won't happen.
It's interesting, like chatting Yvonne and Kurti, your descriptions about family as your support, and like family were my rock in those times. My sister's a nurse, my other sister's a clinical psychologist, and And then I was really lucky that then one of my brother-in-laws is a GP. And so it was actually those guys that taught me those skills, or how to decompress. And it was actually speaking to my sister, who's a psychologist, who gave me coping skills of how to deal with those journeys home and how to decompress. And then my sister's like some kind of connected spirit, and she rings me when you're in crisis and that kind of stuff. And so it is about that art and those soft things that we learn from our community. And it seems like medical schools kind of, and our systems, like, they're not collegial anymore. We're not in a family of medical practitioners. There's competition within us, between us, and it's just like, lads, we need to get back to being a little bit more together to be able to do our work here, because it's pretty challenging. And it's like, how do we beat that back into the system while doing all this other crazy stuff like innovation and science? And
we're just gonna keep all the plates spinning at the same time, isn't that it? I don't know about you guys, but I've found this an absolutely fascinating discussion. It's been an interesting trip down memory lane. Medical school is one of those life-changing experiences that we've all gone through. And hopefully, from the little bits that we've talked about today, we can actually have helped to shape the thinking on what might happen for their future physicians, that they will go through something which gives them a fantastic experience, the knowledge that they need to take forward into this massively changing world of healthcare, and hopefully gives everybody a little bit of perspective and something to think about. As always, thank you to our panel for their expert input and opinions, and thank you for listening. If you have any questions or feedback for us, please do get in touch. Visit mmb.fm and follow us on social. And as always, keep making medicine better. We'll see you next time.